Welcome, future doctors. आज का जो topic है ना, it's incredibly high yield. Whether you're in your ward postings or prepping for those upcoming exams, you absolutely need to know this. हम बात कर रहे हैं premature rupture of membranes की. So grab your digital notebooks, अपना focus एकदम sharp रखो, and let's dive right into this masterclass.
Here's our quick game plan for today. We'll start with what PROM and PPROM actually are, look at the clinical features, check out the diagnostic tests, discuss management by gestational age, go over GBS prophylaxis, and finally, figure out how to manage chorioamnionitis. Chaliye shuru karte hain.
Section 1. What is PROM? Let's clear up these basic definitions straight out of the textbook so there is literally zero confusion later on.
Okay, the terminology here can be a little bit tricky, so let's simplify it. PROM stands for premature or pre-labor rupture of membranes. What's the critical cutoff point here? It's exactly 37 weeks. If the membranes rupture beyond 37 weeks, but strictly before the actual onset of true labor pains, that's PROM. Ab agar yehi rupture happens before 37 weeks. We just attach the word preterm to it. So it becomes PPROM, preterm premature rupture of membranes. That 37-week mark? That is your absolute golden rule. Yaad rakhna isko.
Now, what's really interesting is how we further divide PPROM on a timeline, and you need to know this because your management strategy heavily depends on this exact distinction. If it happens at less than 34 weeks, we call it early pre-PROM. Then from exactly 34 weeks right up to 36 weeks and 6 days, it falls under late pre-PROM. This early versus late distinction is absolutely crucial, doctors. Keep this timeline visually fixed in your mind because हम इसको अपने management table में use करने वाले हैं बहुत जल्दी.
Moving on to Section 2, Clinical Features and Risks. जब patient ward में आती है with ruptured membranes, तो क्या complications expect कर सकते हैं हम?
These right here are your classic, highly tested MCQ points. If membranes rupture early, obviously the fluid leaks out. The immediate consequence? It usually leads to preterm labor, or PTL, within a week. Plus, without that protective amniotic sac, there are greatly increased chances of infection, specifically chorioamnionitis. You also have to aggressively monitor for abruptio placenta, cord prolapse, and oligohydramnios because, well, the fluid is constantly draining out. And for the fetus, respiratory distress syndrome is a massive, massive risk. These are the severe consequences that you must have on your fingertips.
So the practical point is, how do you physically examine this patient on the bed? When you're doing a per abdomen or PA examination, you must contrast two key findings. Dekho, if the fundal height is decreased, it strongly indicates oligohydramnios. Why? Because the fluid is already leaked out. Versus, if you feel the tone of the uterus is increased, like if it feels tense, tender, and rigid to the touch, that points directly towards abruptio placenta. Catching these specific signs in clinical vignettes is exactly how you instantly lock down your diagnosis.
Now here's a golden clinical rule. Per vaginal examination should be strictly avoided, bilkul nahi karna. Why? Because introducing your fingers and push bacteria right up into the uterine cavity, skyrocketing that infection risk. Instead, we always do a sterile per speculum examination. Dhyan se suniye, this is what you are visually looking for. You check the cervix dilatation, you observe for any pooling of amniotic fluid down in the posterior fornix, you absolutely rule out a cord prolapse, and finally, you take a high vaginal swab for culture and sensitivity. This is your standard, non-negotiable protocol.
All right, Section 3, Diagnosis and Tests. Differentiating the exact types of leaking fluid is a fundamental concept, not just for your exams, but for your everyday ward duties too.
The entire basis of our diagnostic testing actually lies in one core biochemical difference, and that is the pH. Amniotic fluid is distinctly alkaline, with a pH of around 7.2. Vaginal discharge, on the other hand, is highly acidic during pregnancy, sitting at a pH of about 3.5. This sharp contrast in pH is exactly the loophole we exploit to verify the leak.
And this brilliantly illustrates exactly how we use the nitrazine test. Let's walk through it step by step like a flowchart, so the logic is crystal clear. Step 1. Apply that pooled fluid to your nitrazine or litmus paper. Step 2. If the paper turns blue, it means the environment is alkaline, which perfectly confirms it is amniotic fluid. Step 3. If it just remains yellow, the environment is acidic, meaning it's just normal vaginal discharge. Bahut simple concept hai, right?
But wait, examiners absolutely love to trick you right here. The nitrazine test can actually give a false positive, meaning it falsely turns blue, if there is any blood, semen, bacterial vaginosis, trichomonas infection, or meconium present. These are your classic trick options in MCQs. Always rule these out before you confidently confirm a positive nitrazine test.
Next up, we have the Fern test.
We take a smear of the discharge, put it on a slide, and simply look at it under microscopy. If you see this beautiful, fern-like appearance, literally looking like the leaves of a fern plant, that confirms amniotic fluid. And why exactly does this happen? That's a high-yield question. It happens because of the high sodium chloride, or NaCl content, in the amniotic fluid. If there is no specific crystalline pattern, then it's just regular vaginal discharge.
Just to complete our diagnostic toolkit, we have a few other key methods you should know. A quick ultrasound will visibly show you the decreased amniotic fluid. Then we have some modern diagnostic kit tests. The Actin test detects placental protein 12, which is also known as IGF-binding protein 1. And then there's the AmniSure test, which specifically detects the PAMG1 protein. Try to memorize these specific proteins, guys. They are very frequent direct MCQ hitters.
Section 4. Management Protocols by Gestational Age. Sit up straight for this one, doctors, because we are entering the absolute highest yield part of this entire topic. This management strategy is absolute gold. Let's break it down logically, column by column. For PROM, meaning after 37 weeks, the main risk is chorioamnionitis. So, what do? We do induction of labor. No steroids, no tocolytics, no MGSO4. Now look at early PPROM, meaning less than 34 weeks. Here we do not induce labor. The biggest risk here is actually RDS, respiratory distress syndrome for the premature baby. So we give corticosteroids to mature the fetal lungs, we give tocolytics to halt those contractions, and we give MGSO4 for fetal neuroprotection. But remember, only if the period of gestation is less than 32 weeks. Finally, late PPROM, which is between 34 and 36 weeks, 6 days. Here the risks are a mix of both infection and RDS. So we don't induce, we do give corticosteroids, but we do not give tocolytics or MGSO4. Are you seeing the logic here? Master this and your clinical management questions are totally sorted.
Moving on to Section 5, GBS Prophylaxis and Screening Guidelines. This step is absolutely vital to prevent early neonatal sepsis.
According to the latest ACOG guidelines, we must screen all pregnant women using a rectovaginal swab between 35 to 37 weeks. However, note these absolute indications where we completely bypass the need for any screening. If a patient had a previous history of a baby with neonatal sepsis, or if the mother had GBS bacteriuria at any point during the current pregnancy, you don't wait around for a swab. You go straight to giving prophylaxis. Simple as that.
But what if a patient presents in the emergency or labor room and her screening status is just completely unknown? In that practical scenario, you administer prophylaxis if any of these specific clinical criteria are met. Preterm labor, PPROM, if the rupture of membranes has lasted for 18 hours or more, or if she spikes a fever of 100.4 degrees Fahrenheit or higher for at least 4 hours during labor. These are your absolute red flag triggers.
And what exact drugs are we giving here? Please memorize these names. The intrapartum drug of choice is benzylpenicillin. If that's somehow not available, your solid alternative drugs are ampicillin or cefazolin. But what if your patient is allergic to penicillin? You immediately switch over to vancomycin or clindamycin. Write this down somewhere, doctors, because it is a guaranteed crossover question between OBGYN and pharmacology.
All right, now for our sixth and final section today. We are addressing the absolute worst-case scenario. What exactly do you do if chorioamnionitis actually develops?
First things first, how do you actually diagnose this highly dangerous polymicrobial infection? You need to understand this diagnostic triad very carefully. Presumptive diagnosis requires ruptured membranes plus a maternal temperature of 39 degrees Celsius or higher, and you need at least one of the following: fetal tachycardia of 160 BPM or more, an elevated maternal WBC count of 15,000 or more, or active purulent discharge coming from the internal os. Remember, things like maternal tachycardia and uterine tenderness are just clinical features. They are not definitive diagnostic criteria. Examiners absolutely love to set that trap, so don't fall for it.
For a truly definitive diagnosis, you'll need an amniocentesis for gram staining and culture or a histopathological examination of the fetal membrane. Now, what's the actual management? We start broad-spectrum antibiotics immediately, ampicillin plus gentamicin. And listen to this part very carefully. This is always followed by a vaginal delivery. A C-section is strictly not preferred. Why? Because it drastically increases the mother's chances of developing postpartum endometritis. You only do a C-section for hard obstetric reasons, like a contracted pelvis or something similar. And if you are forced to do a C-section, you must add metronidazole to your antibiotic coverage.
And that brings us to the end of today's masterclass.
With these structured concepts in mind, are you confident enough to tackle any tricky clinical vignette on ruptured membranes in your next exam? I certainly hope so. Revise this flow, keep practicing those MCQs, keep studying hard to save lives, and I'll catch you guys in the next